This begins Unit 4, Complications of Pregnancy. Objective 41 says correlate factors that increase the risk of complications during pregnancy. A high-risk pregnancy is defined in one in which the life of either the mother or the fetus is jeopardized by a disorder coincidental with or unique to pregnancy. Categories of risk can be genetic, like cystic fibrosis, demographic, like an urban setting, or behavioral, like use of illicit drugs. These three things could make a pregnancy high risk. There are many other definitions of a high-risk pregnancy, but those are just three examples. Risk factors for high-risk pregnancy. There are three major concerns of maternal death. These include hypertensive disorders like preeclampsia and eclampsia, pulmonary embolism, and hemorrhage. Once a pregnancy is determined to be high risk, the physician will perform careful monitoring of the mother and the fetus through the duration of the pregnancy to make sure there is no fetal compromise and no ill effects on the mom. Antenatal testing will be done to detect possible or potential fetal compromise, usually starting about 28 to 32 weeks gestation. Antenatal testing, the major expected outcome is potential of fetal compromise. We want to make sure that the fetus is still in a nutrient-rich, oxygen-rich environment. And fetal testing antenatal fetal testing can identify if that fetus is not getting the nutrients and the oxygen it needs to grow appropriately. Again, monitoring typically begins between the 32nd and 34 weeks gestation, can begin as early as 28 weeks, which is the end of the second trimester, beginning of the third trimester. And the assessment tests are selected by the physician based on the effectiveness and the results showing the big clinical picture. We're not looking at very specifics here. We want to look and see, is the baby growing appropriately? Is the overall environment in utero appropriate for fetal growth and fetal maturation? One test that can be done is fetal kick counts. The nice thing about fetal kick counts, again, they are non-invasive. They can be done at home. The patient should count the number of fetal movements in 1 hour when the baby is typically most active. There should be 10 movements in 1 hour. Nursing interventions and education, if there are less than 10 kicks in an hour, first thing the patient should do is obtain something to eat or drink and recount. If in the next hour there are still less than 10 kicks, they need to notify their physician or the OB unit. In Chapter 9, in Figure 9.1, there is a fetal movement kick count chart, and this gives a way of the patient for identifying the number of kicks and the date based on day of the week. Ultrasound. It provides critical information regarding fetal activity, gestational age, normal versus abnormal fetal growth, visual assistance for invasive tests such as an amniocentesis or chorionic villus sampling, fetal anomaly, placental anatomy, and fetal well-being. Ultrasounds can be done either abdominally or transvaginally, and there's actually a couple other ways ultrasounds can be done, but those are the two that we typically see with OB. And there are three different levels. A level 1 ultrasound is a standard ultrasound. It's just the ultrasound that's typically done for every mom, especially in these smaller community hospitals. A level 2 ultrasound is a specialized ultrasound in which a perinatologist or someone from maternal fetal medicine would do. We're looking more at structure and function of the fetus in utero. It's more detailed, it's more in depth. And then there's the limited ultrasounds. Limited ultrasounds are done to look at one thing specifically, such as we'll do an ultrasound just for AFI, or we'll do an ultrasound for fetal presentation, or we'll do a fetal ultrasound for cervical length. We're looking at one specific piece of the puzzle. In box 9.7, these are the major uses of ultrasonography during pregnancy, and it's based on what we usually use it for first trimester, second trimester, and third trimester. Amniotic fluid index. Amniotic fluid index is obtained by ultrasound. Normal is between 5 and 19 centimeters. Less than 5 centimeters is considered oleohydramnios, and that is associated with renal malformations. An AFI greater than 20 is considered polyhydramnios, and this is associated with GI malformations. A biophysical profile. A biophysical profile has 5 parameters that are either scored as a 0 or a 2. There are no 1s given for a biophysical profile. The 5 parameters are an amniotic fluid index, a non-stress test, fetal breathing movements, fetal movements, and fetal tone. The scoring indications for a biophysical profile, 8 to 10 is normal, 6 requires careful observations, and less than 6 is abnormal and may require immediate intervention, including delivery. If you look on table 9.1, you can see the variables of the non-stress test, what would be an indication of a normal score of 2 or a score of 0. Also the scoring table of what does an 8 to 10, 6, and less than 6 mean. All is located in table 9.1. An amniocentesis is performed with the use of ultrasound to obtain amniotic fluid which contains fetal cells. Amniocentesis can be done for genetic concerns, especially if done in the early first, not early first trimester, but in the first trimester. It can be done to determine fetal lung maturity, and that's typically done in the late third trimester. And it can also give us an indication of fetal hemolytic disease, especially with isoimmunization. Complications related to amniocentesis occur in less than 1% of cases. You can see on figure 9.8 an amniocentesis being done in a healthcare facility. Chorionic villus sampling is usually done in the later first or early second trimesters for genetic studies. It involves the removal of a small tissue specimen from the fetal side of the placenta. And again, typically this is considered transcervically or transabdominally around about the 10th to 12th week of pregnancy. And again, this is done to determine if there's any genetic complications related to this pregnancy. And you can see why this is a concern, because we are moving just a small piece of placenta, which can be then associated with some miscarriages. Your book says that the complications following the procedure include vaginal spotting or bleeding, miscarriage, rupture of membranes, and chorioamnitis, which is an infection of the placenta. PUBS stands for percutaneous umbilical cord sampling. You can see in figure 9.9 an example of PUBS. With PUBS, it's used for fetal blood sampling and transfusion. Indications for PUBS is an inherited blood disorder, karyotyping of the fetal cells, detection of fetal infection, assessment and treatment of isoimmunization, and thrombocytopenia of the fetus. Complications following PUBS, again, miscarriage is always a complication because we are puncturing the umbilical cord. Hematomas, bleeding, fetal bradycardia, and fetal maternal hemorrhage. Follow-up following PUBS is continuous fetal heart rate monitoring for several minutes to an hour, and a repeat ultrasound in 1 hour to make sure there is no bleeding or hematoma formation at the puncture site.